What happens when psychiatry ignores its own harms? Today I'm sitting down with Dr. Awais Aftab. He is one of the most influential and philosophically minded psychiatrists out there, and I have to say, one of my biggest critics. And I'm going to be asking him the hard questions about how psychiatry is practiced in the US today, such as why are so many people suffering from drug side effects that no one warned them about? Why has the field stayed silent for decades? And can psychiatry be reformed from the inside? Now, this isn't just a debate with someone who disagrees with me a lot. It is a deep and critical look at the future of mental health care. I'm here with Dr. Awais Aftab, who has agreed to come on the show. Thank you so much for taking time out of your day to speak with me and my audience.
Thanks, Josef.
Yeah. So just to provide some context of Awais, if you're not aware of him, he is a psychiatrist, and where he fits kind of in everything at the moment is he's critically oriented, and so he's rose to quite a popular position. I would actually say he's one of the most influential psychiatrists out there these days. I don't know if he set out to become the most influential psychiatrist, but he has a very popular Substack. He's widely followed on X. And one of the reasons he has become so popular is, one, he's a very good writer, but I think the most important reason is that he's not afraid to engage with people who have ideas very different to his own. And because of that, we're often arguing with Awais on Twitter, or X as it's now known. And if you want a front row seat of that, you can head over to X and sort of follow. And so what makes Awais interesting from my perspective is that he's very critically oriented, he's philosophically minded, but in many things he's disagreeing with me, he's disagreeing with Joanna Moncrief, Mark Horowitz, and so we often clash over ideas. And despite that, we're able to sort of get together and chat, and I think it's going to make for a really exciting interview as we explore various issues from very different opinions that are affecting psychiatry today. So that's what we're going to be talking about.
I look forward to the conversation.
Yeah. So there may be some polite sort of hostility or some challenging points as we go through this. I've also invited Awais to sort of challenge me as well during this interview, to call me out on some of the things that maybe he disagrees with, that I say and do. And so I think that could be really fun and engaging. So with that introduction, how about we get into it? Does that sound okay?
Yes. Yeah. Let's move on.
So Awais, I'd like my audience to understand you a little bit better before we jump into this. Maybe could you tell us a little bit about how you became interested in psychiatry?
Sure. So I'm originally from Pakistan. That's where I was born and grew up and did my medical school. And then I moved to US for psychiatric training and did my residency here in Cleveland area at one of the Case Western Reserve University hospitals. And I had been interested in philosophy since an early age. And before med school, I was even considering potentially going into philosophy professionally, academically. But in Pakistan, it was not very well developed as an academic discipline and was not a very viable professional path. I had a lot of physicians in my family. I ended up in medical school, and I realized pretty quickly early on in medical school that given my temperaments, my interests in philosophy and psychology, psychiatry was the right fit for me. So I was gravitated towards it. I leaned into it and eventually made the decision. There was some kind of consternation and kind of concerns among my family about that decision. They didn't understand the discipline very well. And in Pakistan at the time, the discipline was very stigmatized as well, although things have changed somewhat since then. But I went ahead with that because I thought that if people like me don't go into the profession, then how things will change. But because of my prior interest in philosophy, I was very drawn to a number of conceptual and philosophical issues that surround psychiatry, the historical anti-psychiatry movement. And then kind of in the 90s, there was this burgeoning academic discipline of philosophy of psychiatry, in which philosophers, psychologists, psychiatrists, and many other people from many other disciplines were participating as well. So I found myself really attracted to those questions, and I started reading into that a lot more, and I kept up with that during my psychiatry residency. And in the later years of my psychiatric training, and then in the years subsequently following that became my academic area of focus, kind of contributing to the philosophical and conceptual literature on various issues around diagnosis, classification, various issues around how to understand psychiatry as a scientific discipline, how to understand the nature of explanation in psychiatry, and also conceptual issues around how to understand medication effects and issues like that. So my academic interest has been much more conceptual, abstract, philosophical, and if you look at my published academic work, you'll see that. But I started becoming more active on social media in later years of my residency and fellowship, and then as an early career psychiatrist. And I was struck by the discourse that was happening around psychiatry. And it was intriguing to me that a number of questions that had been discussed in philosophical circles, in an academic context, were also being discussed on social media and popular discourse, but they were being approached to a different set of assumptions and to different ways. And so this whole kind of movement around critical psychiatry that had sprung up and that had been popular. There was interesting intellectual overlap between the philosophy of psychiatry stuff and the critical psychiatry stuff. And I saw that one way in which I could be useful could be as a bridge between these two communities and these two areas of thinking. And that led to my interview series for Psychiatric Times called Conversations in Critical Psychiatry, which went on roughly from about 2019 to 2022, in which I'm engaging with a number of people who are working on the critical psychiatry side of things. I'm also talking to a number of people who are working on the philosophy of psychiatry side of things, history of psychiatry. And I'm personally using that to kind of draw connections, challenge people, and present new ideas. And I'm fortunate that series was well received in the psychiatric community. And last year it came out as a book adaptation as well from Oxford University Press. So that gives you a little sense of the intellectual background I'm coming in from.
And it's so the thing that I read that series, quite a few of them. I read the one you did with David Healy, with Giovanni Fava. Did you talk to Joanna or Mark Horowitz for that? I don't know if you did back then. Okay.
So Joanna Moncrief was part of that. David Healy wasn't, unfortunately, but Giovanni Fava was that. Horowitz, he was not a part of that one. Okay. Yeah. So but Moncrief is there, Sami Tamimi, then in the published book version, Duncan Double, who's also one of the kind of co-founders of the Critical Psychiatry Network. So I did get several prominent people from Critical Psychiatry Network as part of it.
Now, I don't know Awais' perspectives fully. I hope we're going to get into that today, but an interesting way to sort of set this up is I've read the work of Giovanni Fava and Joanna, and I guess where I've fallen down, as the listeners to this show will know, is where I think psychiatric medications are actually extremely dangerous, and they're massively overprescribed, probably by a factor of about 20, and they're a big issue. I don't think that's how Awais feels, although he has read a lot of the similar things that I have, and he's interviewed people. And I think it's going to be really important that we explore these differences. And so I think what a nice place to start would be is, Awais, maybe you could just talk about what are your thoughts about how psychiatry is currently being practiced in the United States?
Yeah. So, I mean, I'll before I jump into it, I'll say that I share a lot of concerns about how psychiatry is practiced and the way psychiatric thinking has been. And I think when it comes to issues around, for example, medications being overprescribed or being over relied on, and our kind of track record of medication safety and iatrogenic harm, I I agree with all of those things in principle, and I even support them. I think where the differences, kind of some of them get highlighted, is in the way we generally think about the nature of mental illness, and how we think about the potential therapeutic role of these kind of medications. So I think that's where the fault lines are between, I would say,
Mm-hmm.
the way I think and some of the more traditional critical psychiatric route. But we'll get into that. I just wanted to
Sure.
say it outside. So
Yeah.
from my perspective, what I see as some of the problems with the way psychiatry is currently practiced, in the Western world, but in many parts, is to one, it is very conceptually impoverished. I think the average person who gets a psychiatric assessment, it's very rudimentary. It's very focused on superficial symptoms. It's very focused on a certain subset of symptoms that DSM-ICD kind of criteria refer to. And most people don't get a comprehensive evaluation, for example, of the role of temperament, of the role of kind of developmental factors, their psychosocial history, and various other kind of lifestyle factors and those kind of things. So it's a very superficial assessment focused on a selected selected classes of symptoms. It's very focused on these categorical, diagnoses. And then those categorical diagnoses are followed by an algorithmic kind of thinking about, oh, if you have major depression, then you follow this treatment algorithm for medications. And if you have generalized anxiety, for example, we follow this kind of, so it immediately latches on to this medication treatment as the default kind of thing, at least in a common psychiatric setting. And then the emphasis is generally on starting people on medications without much discussion of, what are the relevant serious side effects that we need to take into account, or how long the treatment duration is going to be, what to expect, and what coming off medications might look like, and what kind of challenges might be involved. And so it's a very it's like, what are your symptoms? Here's your diagnosis. Here's the medication treatment. And then either physicians are not really communicating any kind of narrative understanding of what all this means. They'll say things like, depression is they might say medical disorder if they're being, more generic, or if they're being very concrete, they might say things like, oh, it's a chemical imbalance, for example, in a common language used in the past, or they might say it's a brain disease, like, a disease similar to diabetes. They might say things like that. And they might, with regards to the medication, they'll just kind of emphasize the medications being safe and effective without kind of going into details of what any of that means. So from my perspective, the patient is left with a very inadequate understanding of what does it mean to have a psychiatric disorder? What does it mean that depression is a medical condition? And they're also left with a very inadequate understanding of what the treatment is intended to do to them. And that makes them susceptible to a lot of kind of popular reductionistic kind of ideas about, what mental illness is and what its treatment is. So, in the public education campaigns that took place in the 1990s and 2000s, the emphasis was very much on, characterizing mental disorders as brain diseases, chemical imbalances, and medications as correcting or fixing those imbalances. Now, even though that was not the correct scientific understanding of these things, even among academic psychiatrists and researchers at the time, But for various reasons, people just kind of latched onto that language, and it became
Well, I
the
think drug companies threw a couple billion behind that language as well,
yes,
which was a big problem.
yeah. Yeah, drug companies, direct to consumer pharma advertising, and then also, the physicians who were working in coordination with pharma, either doing their CME talks for them or, becoming key opinion leaders, etc. They were using that language too. So it was kind of pushed by pharma and also pushed by physicians, who were working with pharma. And then once it became a popular cultural metaphor, or you started hearing this phrase show up in TV shows and magazines, then even normal, well-intentioned doctors, primary care psychiatrists, they started using that language too, seeing that as a benign thing. So the cultural understanding that developed around, depression, anxiety, other conditions was a very simplistic, reductionistic one. And so when we see the impoverished nature of the average clinical encounter, and we see that, nothing really is being explained, the patient is going to leave with that, popular cultural understanding reinforced. They're going to think that, yes, I do have some kind of a chemical imbalance or a brain problem, and this medication is doing something to, correct it, fix it, etc. Which is kind of the reality, as we all know, is much more complex. One, these are, the psychiatric diagnostic category are simply symptom clusters. They in fact, they're very heterogeneous symptom clusters. They don't even, they don't refer to one kind of thing. It's a mishmash of various kinds of mechanisms. And these mechanisms don't respect the boundaries of DSM and ICD. So the kind of, to the extent that we understand what these mechanisms are, they crisscross across different symptom clusters, and they're very much enmeshed with psychological processes, with temperamental factors, with life events, life stressors, and they're also very much kind of enmeshed with developmental factors, with childhood adversity, childhood trauma, etc. So it's a complex, multi-causal kind of picture in reality.
Okay, so if that's to recap, you've mentioned that there's a simplified understanding of mental illness, which is reinforced by very short visits. It often leads to medications. You've also mentioned you think the meds are overprescribed. But what's the deal? Like, what are the consequences of this? How does this affect patients? What are the consequences of these flaws in the system that you've highlighted?
So the consequences, I think, are twofold. One, they are kind of conceptual and narrative, and then on the other hand, they relate to treatment factors and kind of iatrogenic harm-reduced treatment. So conceptually, one, I think people are conveyed a distorted understanding of the nature of their problems. Thinking of these complex, multi-level problems as, primarily caused by, some kind of brain dysfunction, disconnects people from the, from what their emotions are actually trying to convey or signal or tell them. It disconnects them from the, from understanding their emotions as conveying meaningful information, or, as representatives
and just to
of other kind of psychological information.
Sort of to just speak to that, you mentioned multi-layer problem. Now, I'm assuming you're talking about, these could be things like work problems, relationship problems, problems in meaning, but also broader things like poverty, political issues and things like that, or maybe medical problems as well. Is that what you're meaning when you're talking about the multifactorial nature of depression, or was there some other slant in there?
Yes, yeah. So I think that there are all these different factors that exist across, what scientists or philosophers called kind of levels of organization or levels of analysis. So we have the the physiology and neurophysiology. We have what's happening, a phenomena in cognitive psychological terms. We have various, phenomenological existential aspects. And then we have these various, kind of social cultural factors and structural factors in terms of social determinants of health. And I think what is distinctive about mental health problems is that they're arising from a combination of these things. For example, if you look at some of these larger studies that have looked at depression, anxiety factors, and have tried to analyze what explains a big chunk of the variance in depression, anxiety symptoms, the factors that tend to come up, most significantly tend to be one, personality factors like neuroticism as a personality dimension, and then life events, both childhood adversity as predisposing people, but acute life stressors as kind of precipitating acute stressful depressive anxiety episode. So in a very simplistic kind of model, we are seeing an interaction between high neuroticism and adverse life adversity, both childhood trauma as well as acute life adversity, and that acts in coordination to push people over the edge, you can see, and there's a phase transition in terms of what they're experiencing, and they're pushed from a relatively healthy kind of psychological state to one characterized by these persistent depressive symptoms, anxiety symptoms. Now, I deliberately use that as a very simplistic analysis, neuroticism and life events interaction. But in reality, there's a lot of other stuff going on. You're looking at the state of inflammation in your body. You're looking at what else, what's happening in the immune system. You're looking at a wide variety of other things, the level of, brain energetics and those kind of things. And then there are other, psychological developmental factors too. So it's a variety of things acting in coordination to maintain a state.
And I think, what you mentioned there, it would probably be a very intuitive way to look at depression, which I think is natural for many people. Some people are nervous Nellies. They're going to be hit more by stresses. Maybe an intervention for them is, some CBT or something that's psychotherapeutic, allowing them to regulate their stress. Some people have inflammation because they have food sensitivities. Maybe a dietary intervention could be helpful for them. Sometimes it's just life problems. There's been a death in the family, and we simply need clergy or family support to wait with them while it goes away. Or there's medical problems, and sometimes we just don't know where it's coming from. And if you've tried everything else, potentially medication can be an option. Now, I think what you're saying is that we've sidestepped this multifactorial kind of perspective of depression. We've simplified it nowadays, and we're very quick to diagnose off DSM criteria and sort of forget the complexity of it and all of the different interventions that might come along with that, and just focus on medications. Is that a fair summary of
that's, yeah, I think in broad strokes, yeah. And I think, what makes this even more kind of frustrating is that it's not even that people are following the DSM-ICD criteria in practice. If you look, for example, at what happens in primary care settings, people are not even being diagnosed with major depression based on a threshold set by DSM or ICD. It's like, you get a little bit of a high score in PHQ-9, for example. If the person just says, hey, I'm really stressed and I'm really stressed out and depressed. And, so there's not even a kind of, minimal diagnostic assessment that is recommended by DSM and ICD taking place. It's very superficial and driven. So, for example, a lot of adjustment disorder style problems, people just getting stressed out at work and having, let's say, time limited transient difficulties, they might just get characterized as major depression because, anything that presents with some kind of low mood dysphoria kind of thing just gets the depression label. So it's not even, we're in this state where the labels are just being applied willy-nilly, the criteria not even being respected, which makes it more problematic. Now, there are reasons why this is happening. One, primary care physicians and many, I would say many general psychiatrists too, they're just really overworked, that they don't have enough time to even, sit down, properly chat with people and get a sense of, the scope of the problem, the nature of the problems. And they don't have time to explore what it is that the patient prefers in terms of treatment, what it is that the patient actually wants, what are their expectations for treatments. And how can, the medications, the other things that are being offered, how can they address those things? The time for all, there's no time, energy available for all these kind of careful, nuanced, discussions to take place. it just gets kind of defaulted into, either the patient gets screened for, symptoms using PHQ-9 or GAD-7, or the patient presents with symptoms, but, they just automatically, they only have kind of one thing to offer. So they offer that to them. So there are big systemic issues involved as to why this is happening.
Let me ask you this. How do you feel about the leaders of psychiatry at the moment? Not mentioning anyone in particular, but the leaders of the academic institutions, maybe the professional organizations, who are sort of tasked with the responsibility of driving the profession, in a way that cares for people. How do you feel like the leaders in our field are doing at the moment?
In terms of, you mean in terms of their responsibility to bring about change in the practice?
Yeah. Well, I mean, we talked a lot about the problems with how psychiatric care is being delivered, both by psychiatrists, but also by the busy family medicine doctors sort of in the trenches. But ultimately, we as psychiatrists, we are the ones that help our family physicians and our OBGYNs. We're the ones that set the standard. And there are a lot of problems going on in psychiatry. And my position would be that it's been pretty bad for a very long time. I would say at least 3 decades. I would say there's been serious problems. And so I guess I want to ask you, how do you, and I just want to say to my audience, this is really easy for me to sling mud. I work independently. I'm self-employed. Awais is affiliated with a university, but I will give him a chance to share some feelings about this. How do you feel like the psychiatric leadership is doing at the moment with all of these issues going on?
I think that they're aware too, at a variety of kind of levels, about the nature of the problem. I think there's a general sense of helplessness. I think there's a sense of helplessness about the systemic factors, and then there's to a certain extent there's a sense of denial, perhaps too, about the severity of the issues. And so, so for example, everyone is aware that, that treating depression in the usual, primary care setting or a 15-minute med check kind of setting is not the optimal one, and if you look at, in fact, if you look at the treatment guidelines themselves, the treatment guidelines, recommend a very thorough assessment and, taking into account all of these kind of, quote unquote biopsychosocial factors, etc. But no one knows kind of, there's such strong forces operating on the healthcare industry, economic and bureaucratic forces pushing physicians to, act in these kind of way that these psychiatric leaders themselves feel kind of helpless about. And, for example, they have been, one of the things they have been pushing for many years was, a mental health priority in terms of insurance coverage, because we didn't even have that in the US for and still there are problems. And so they are aware, I think, of those things, but they just they're like, they don't know what to do about them because the problems are bigger than what the profession can address by itself. And then so that's, I think, the helplessness part. So they just they issue their recommendations, they issue these textbooks and other things, which are, I mean, if you look at the actual guidelines, they do seem to make a lot of sense. But what gets implemented
I might push back against you on the guidelines, but I don't want to I don't want to interrupt your line of thought. Go finish that, then we'll talk about the APA guidelines for depression. Yeah.
Yes. Yeah. So the other, I think the denial part comes in with regards to, I think, the iatrogenic, prospect, the iatrogenic harm of just, using antidepressants very, very casually. So they might say, well, so what that, everyone with, people with mild depression or subthreshold depressive symptoms is getting an antidepressant in primary care. They're suffering, they have some kind of a problem. So what if they get medication? And I think that's where, I think the issues with, for example, antidepressant withdrawal and issues with sexual side effects and those kind of things, I think, have not been taken as seriously. And part of the reason was that the evidence base was distorted. We in the late 90s, NIMH decided that they were not gonna invest that heavily into clinical research, and they decided they're gonna invest in basic science more and leave clinical development to pharmaceutical companies and other in academic institutes or other smaller funding groups to do clinical trials, if to the extent that they wanted. So which pharmaceutical companies are obviously interested in highlighting efficacy of the medications and getting FDA approval. They're not interested in long-term safety because it's why would they be? And the other academic funders other than NIMH, they just none of them have made iatrogenic harm or medication safety a big priority for them. So there was no research money going into studying medication safety in any kind of rigorous way. So we had this big gap, which meant that, people on the ground who were having serious medication-related side effects, they were not being recognized in any meaningful kind of way by the profession, which led to this, as you already familiar, waves of people with serious antidepressant withdrawal issues forming online communities and trying to figure out self-help thing. And it took years before the profession, woke up to the magnitude of the problem with antidepressant withdrawal, and has just begun to address that in recent years in some ways. But because we lack high quality data and high quality evidence, the scientific discussions tend to be hindered because the way to resolve disagreements is by high quality data, and if you don't have data, then people gonna continue to disagree, and it's hard to resolve that. So that's I think the other is that due to a variety of factors, the harms that are have been underestimated and underacknowledged.
I'm going to tell a different story, but one that complements what you've shared, and that is we don't need any clinical trials or even I would say observational studies, although they would be impossible to detect things like PSSD or protracted withdrawal injury. Really what we needed was people to take them seriously, because when you're looking at potentially uncommon side effects, things that are idiosyncratic, they don't occur in the vast majority of users. Causality, the causality assessment, determining whether or not something is real, it really happens through, I'd say, case reports, or as other people may know it as anecdote. When you're dealing with rare side effects, you simply need to listen to people, and eventually, once you have enough of them, and there's a similar clinical presentation, it can be enough that it spills over. I think that has been acknowledged now more widely, but benzo buddies, surviving antidepressants, we're talking about hundreds and thousands of Americans and people all over the world have been talking about this phenomenon where they come off the medications and a few months later they develop irreversible, not exactly irreversible, they develop severe neurological problems that don't go away when they start the drug again. They eventually do abate, but they're much more like a neurological injury or like a severe concussion, and sometimes it can take years for people to normalize. People have just been ignoring this. The psychiatric profession has not been taking it seriously, and the narrative that I wanted to paint around that is that academia, in many ways, I don't think they want to look at these problems. I do think the upper echelon of academic psychiatry, many people within there, have become heavily biased. I do think there's, and maybe you feel this in your career, I don't know if your aspirations are to become a professor, but you may look around at your other academics and say, wow, they're doing really well because they've got pharmaceutical companies writing their protocols, letting them run clinical trials, giving them support. It's probably a lot more easy to get grants to do pharmaceutical research than it is to do philosophy of psychiatry. And to work with drug companies provides heavy career advantages. And what I observed, being at a few different academic institutions, is that the top level has been biased in a way where they only want to talk about the benefits of the drug. It would almost be disadvantageous if you were to start saying, guys, I actually think we're causing a lot of problems. I think withdrawal is more serious than not. You're not going to be picked out of the group of experts to run the studies. And so I think there's been this corruption going on where our leaders, the leaders that are there that are meant to be protecting people, have become biased in a way where it's taken us 30 years to acknowledge a problem that should have been picked up, ideally within the first 5 years, possibly 10, for the protracted withdrawal. And that's same with PSSD. I think when these issues come up, they're often denied. Because they're very inconvenient. And I think leaders don't want to, academics, they don't want to talk about it because it's simply not good. And so I don't think we needed more research on these areas. I think we needed people to stand up and actually listen to the patients. And speak back, and I'd love to hear your thoughts about that. I mean, that's how I see things. I'd love it if you could tell me, Josef, you've gone too far. That's not how I see it. I want to get your perspective on this because that's how I felt. Yeah.
That these kind of patients have not been taken seriously especially with these more rare, kind of poorly understood side effects such as protracted withdrawal and prolonged sexual dysfunction. But I disagree that we don't need studies around that, or so think about it practically. What are the pathways through which such complaints would be recognized now? What happened was that, in the absence of scientific evidence consensus, if a person shows up to their primary care and says, hey, I just, I tried to, I've been, trying to go off let's say my antidepressant, my citalopram or whatever, and I'm just having this really terrible time, and it's been, it's going on for months, and I have to do it very, very slowly. Now, what is that primary care going to do? He's going to, he or she is going to look to the scientific literature for guidance. They're going to look to, well, what are the textbooks saying about it? What are the guidelines? Because, they haven't themselves, seen that before. And not finding anything, they'll be like, I don't know what to make of it. It doesn't look like this is a very, widely recognized condition. Maybe this is just, your depression, anxiety acting back again. Similarly, let's say if someone, goes off their antidepressant and they're having persisting, sexual problems, what is the primary care going to do? They won't know how to make sense of it. Now, so there's going to be confusion, and if those people, immediately, let's say, leave the system, so they have a negative encounter with, with their primary care or even with the general psychiatrist, and then they're like, oh, I'm done with the medical system now. I'm just going to go online and talk about my experiences. So let's say clinicians hear about this from, people talking about it on Reddit or other online forums. They don't know what to make of it. They themselves have not evaluated the person. None of their colleagues that they know have written about it. And so it's like, hey, someone on the internet is talking about some concerning side effects, but they have no way of authenticating that themselves. So they might get exposed to it, at least the ones who are online, but they don't know how seriously to take it. And so I do think, it hurts if we don't have a dedicated clinical, service. We don't have a dedicated research program that is aimed at, providing kind of, evidence in a manner that people in the profession can take seriously. It's hard for them to know, among all the noise on the internet, what information, to be taken seriously and to be authenticated, what not. And so that's one thing. I think, we have to think about the ways and what are the channels through which information becomes authentic in medical circles and scientific circles. And the second thing is that I think, unfortunately, a lot of the communities in which people were people were joining to talk about medication-related harms, they I think rapidly developed a strong quote unquote kind of anti-psychiatry kind of flavor, where they became, due to their understandable negative experiences, they became very angry towards mainstream medicine and mainstream psychiatry. And they started kind of immediately, they started denying that, medications have reasonable, for example, efficacy at all, or there's a legitimate clinical role for that. So what the clinicians and what the academic psychiatrists are seeing is that a bunch of really angry people online who just hate medicines and don't want to acknowledge efficacy and don't want to acknowledge clinical use, and they're also saying negative side effects. So I think this linkage between the kind of denial of medication efficacy with, I think it made people rank. People, if you make an issue, an anti-psychiatry kind of issue, the average academic psychiatrist is not going to want to touch it. Why would they, go out on a limb to try to something that is perceived as being threatening to the profession? So I think the hostility that developed towards some of these medication stuff actually hindered the community from making an effort to try to, study this effect too. Now, I'm not saying that's the primary reason it happened. I'm not trying to blame them, but I did think it played a role.
Well, what I would say is, I understand the hostility because, these weren't issues that came up recently. And there are mechanisms by which these things are discovered, right? If someone reports a side effect, you do a FAERS report form. It goes to the FDA. The FDA is meant to be looking at these things. What we've done in psychiatry a lot of the times, whether it's with protracted withdrawal or PSSD, is we don't even try to figure out what's wrong with people. We blame their underlying conditions. If there's a suicide on a drug, we blame the patient. And so there's this laziness, I would say in drug detection in psychiatry, where it's so much easier to just blame someone, even if they have unusual physical symptoms like the genital numbness in PSSD, or the neuropathy that happens with protracted withdrawal, which really can't be explained by the underlying condition, but they do. And I used to work at the FDA. I'm very critical of the FDA. I used to work in pharmaceutical companies as a drug safety officer, evaluating case reports. I've had colleagues. I know how people look at these things. They are not observed, and they are often, even at the FDA, it's just easier to say that it was due to the underlying medical condition. There's also been this effect where I would say the pharmaceutical industry, in a way to defend criticism against medications, they've often said that all criticism is coming from people who are either Scientologists or these old school psychiatrists who just believe people should pull themselves up by their bootstraps. They lack the appreciation that, mental health conditions could have a biological component. They're very all or nothing. So they've told rank and file doctors and academics that when you hear criticism, it's coming from cranks. It's coming from people who really don't get the complexity of this. That trickled into the FDA. I saw that with the division director, with the different colleagues there, and they were acting more like advocates for the medications than real scientists. David Healy submitted a PSSD petition back in 2018, which still hasn't been acted on. They're just sitting around twiddling their thumbs with it. And so imagine this. If you had someone that you loved, a sibling or a child, and they develop this condition, PSSD, and then you go, oh my God, what is this? And then you go online, and there's, tens of thousands of people there. And then you start to see that since the 1990s, there's been reports of PSSD with imipramine, and there's been several more throughout the 2000s, and more articles there. You would think, what the hell is the FDA doing? What are academic psychiatrists doing? Because it's just ignored. It's not like it's been picked up at any point by these people and saying, hey, we found these concerning things back in the early 2000s. Wow, that's scary. Let's address that. It is simply ignored. Surely there has to be some, I get it. Yeah. If you're a family physician, I'm not blaming the family physician who's there saying, listen, there's no guidance. It's not in the drug label. How could they know if it's not in the drug label? we're really talking about a failure of leadership in psychopharmacology of the experts who are out there, who are meant to be protecting people and informing them of these things. And that is completely broken down, even with antidepressants and suicidal behavior. I mean, that reared its head in the early 90s. It wasn't until 15 years later that they even got a boxed warning. And it was waved away by many academics as just being, oh, we didn't see it in the clinical trial, even though there were heaps of people there where it's happening. And so I do think there's a lot of justification that people should be extremely unhappy with our psychopharmacology leaders for essentially just taking very limited interest in doing research into these harms, because I mean, drug companies aren't going to pay for this stuff. This has to be pressured from the psychiatric leaders who it's crickets. It's absolutely crickets out there.
No, that I agree with you. I mean, I think, the silence around safety issues has been very concerning, and it has been, a big frustration, for me as well. And oftentimes when, I think many of the psychiatric leaders, when they do get, asked to comment on those issues, let's say by the media, they're often really defensive, and their main concern tends to be that we don't want people to get scared away from seeking medications or seeking help, and and they're not balancing that with this prospect of what if these medications are really causing harm to some people, and what responsibility do we have to these people who experience these serious difficulties. So why the profession has not taken this seriously, really, I struggle to understand.
You know why?
I mean, vested interest in, psychological diagnostic. Now, there are some, my understanding is that when, I think about 4 or 5 years ago, when European medical agencies, finally issued the warning regarding, protracted or persisting sexual dysfunction, persisting beyond this condition of antidepressant, it resulted from a very comprehensive kind of list of cases that David Haley and colleagues had submitted to the EMA, and these were real world patients that were named. So this was not a de-identified. They actually submitted that here's a list of these. I don't know how many there were, 300 or something.
With cases, their doctors who agreed to be interviewed to say that there was no alternative factors that they could find. Yeah.
Right. Yeah. So there was patient experience, and then there was clinical kind of, a clinical observation and other kind of, reports showing that, and finally that was enough to, for the EMA to present that kind of thing. And I think, in order to convince the general community of that kind of thing, we need more of that. A person just kind of, sharing their experience, on the internet, unfortunately, it's just not going to be enough to be persuasive, to a lot of other people with depression. So what I think a lot of psychiatrists would want to see is that people who are working with clinicians, where their clinicians kind of, providing a thorough, history and assessment of here are different factors that we look at, and then maybe even, information from urologists or other people who have done a comprehensive, assessment of the sexual problems too, and have clarified that there are no other factors.
The patients have the responsibility to tell their doctors. The doctors have the responsibility to report it to the FDA. But the fact that David Healy had to put this together, doesn't that say that there's something really wrong with our drug regulators, that we have an independent academic collating 20 years of research and putting together case reports which have been trickling into regulators? That's crazy. And I mean, there's something really wrong if that's what it's taking.
No, it is. Yeah. And it is astonishing. Yeah. I think, like I said, there's a big gap. I think that there's no mechanism in place that is really trying to understand, or really trying to even discover and, uncover, especially these more, relatively uncommon side effects that don't show up in these larger studies when we do that. So, and the FDA report system, it's too noisy, and it's basically just one clinician expressing suspicion. And, we definitely need better ways of doing that. And it requires, it will require action at the, top organizational level, and I think from my point of view, I think what will help the most is that if NIMH came out and said, for us, iatrogenic harm is one of our, research priorities, and we will fund, studies if you provide that, if you're looking into it. I think I think major funder has to come out and say, we're making medication safety one of our research funding priorities. And then if you dedicate money to that, then we will see, actionable data come out.
I'm glad you brought up the NIMH. I'm going to make sure we circle around to the esoteric and useless research coming out of the NIMH later on. My perspective.
Well, I wouldn't necessarily agree with. I think there's a lot of useful, valuable stuff coming out of NIH, but there are gaps, I think, in priorities for sure. Yeah.
Yep. Yeah. That's my statement. So we've talked about harms. I know we're focusing on antidepressants, but I do think it's the best drug to talk about because it's, last I checked, I mean, there's a lot of people taking them. I've seen anywhere from, 11% to 15% of people are on meds for anxiety and depression. Big proportion of our population. And so we were talking about, there's some serious harms there, PSSD, protracted withdrawal coming off. But then there's the question of efficacy of these medications. So my perspective is there's no good evidence that they really work long term. And I want to level set with you and get your perspective. What do you think about the evidence base behind long-term antidepressant use?
It is understudied. I mean, and we don't have high quality data, on that, which makes things difficult. But I think that the data that we have, for example, in the short term, and I think we have a number of maintenance studies looking at things that up to 1 year, or sometimes sometimes a bit longer. So they are generally, they do show a signal of efficacy. They do show that medications, for example, like reduce the risk of depressive relapse, and and for anxiety disorders, help control symptoms. Now, I think based on clinical experience, a lot of people would say that benefit extrapolates, that, just because a person has been on an antidepressant 3 years or 4 years, it doesn't mean that the benefit goes away. Another thing that I think that I find interesting is that a lot of the maintenance studies have used a relapse prevention strategy of looking at whether the medication is working or not. So what they're comparing is that if someone stays on an antidepressant, let's say, and they're generally kind of doing okay, if they stay on antidepressant, does the risk of a future episode of depression goes down? That's the question that most of the existing studies have looked at. Versus in the kind of patients that I see in a general psychiatric setting, these tend to be people with chronic depressive anxiety symptoms that live with certain degree of depression and anxiety on a day-to-day basis, just as a person with, let's say someone with chronic pain lives with pain on a day-to-day basis. For them, the question is not, hey, I want to prevent a future episode of depression, although sometimes that is also relevant, but oftentimes it's like, I'm living with these day-to-day symptoms. Is my medication helping me manage that? Or I'm living in really stressful, conditions. Is my medication helping me, restore some degree of functioning to that? And that is where I see the medication do pretty well, and where I see most of my patients who stay on medicine and who kind of, who are satisfied with them, is that what they report is that staying on the medication helps me. I think a lot of people who feel, let's say they have, depressive episode and then they get better and they're completely fine. I think a lot of people just naturally come off the medicine because, the average person doesn't really want to stay on medication that long. And even in many kind of research studies, the adherence rate, don't tend to be high. So I think people oftentimes stay on medications because they're getting some kind of active benefit from them, in a dysthymia-like picture, for example, or chronic generalized anxiety-like picture. And another thing I want to say is that, we focus on depression as the clinical indication, but anxiety disorders are just as common in primary care setting and general psychiatric settings, and often anxiety disorders tend to be more chronic than depression as well, which often tends to be more episodic in nature. And so I think that's another difference too, where I think the people who are staying on antidepressants, at least among the cases that I treat, tend to have very prominent chronic anxiety symptoms, versus the research studies tend to focus more on episodic major depression. So there are discrepancies. I think it would be great if we had a variety of long-term medication kind of efficacy studies looking at outcomes at 2 years, 3 years, etc. We don't, and I think it's partly because I think it's difficult to do in a placebo-controlled manner. Saying someone, hey, we're gonna randomize you to a study that's gonna last 4 years, and you may be on a placebo for 4 years. I mean, how many people are gonna, be willing to sign up for a kind of study like that? So there are, I think, recruitment challenges, kind of things too that come up.
Yeah. So, well, just to sort of tease this apart, yes, so we don't have placebo-controlled studies that go over a year, pretty much. Maybe some of them go slightly over, but mostly the longest ones I think are about a year, and most of them are around 3 months. And so I think the statistic I saw recently was that 50% of antidepressant users, at least in the US, have been on them for over 5 years, or close to 50%. So they're long-term users. And then so the short-term data with the placebo control is, they're less than a year. And then we go to the relapse prevention study, where people are enrolled for about 8 months or so, typically. A large number of them, we don't know how many, have probably been on antidepressants longer. These studies aren't pulling in people who are using antidepressants for the first time. So usually it's antidepressant users who get transitioned onto the drug that they're studying. But then they taper them. When they do this, and so just for the person who's not familiar with this, the relapse prevention study, imagine you enroll 500 people, you put them all on an antidepressant, and then 8 months later, randomly you select 250 of them and they get transitioned to placebo. And then you follow both groups for a year to see how many people become depressed. That's the design of the study. But this transition, the taper is done maximally over 2 weeks, on average 5 days, and from several of the studies immediately with no taper. So we're essentially talking about transitioning people who have been on these drugs for at least 6 to 8 months, but possibly years going into this. And as you might expect, there is a difference in the level of relapse. And then when people have looked at this, most of it happens in the first 3 months. The placebo group will relapse at a higher rate within the first 3 months, and then both of them relapse approximately at the same rate after that. Now, the FDA and academic psychiatrists out there have said, wow, this is proof that these drugs prevent relapse. But the methodology is so flawed by what we know about the incidence of withdrawal and the severity of withdrawal. And also there's no design elements in those studies to differentiate antidepressant withdrawal from depressive relapse. They simply do not try and do that. Now, I'm not saying that, this should be evidence that that these drugs can't prevent relapse in some people. Obviously, I've talked about this on my channel. I believe there's a drug effect. I think it can be therapeutic for some people, and removing it could cause a return of the previous symptoms. I think that's true. But the point I really want to make is relapse prevention studies are shit. They're too methodologically flawed to actually be leaned on by anyone to say, this is proof that we should give these meds to people long term and they're efficacious. I mean, that's where I fell down on it. Am I being too harsh? I mean, what do you think about the design of these studies? And I mean, I nerd out on this. I don't know how familiar you are with the studies, so I won't hold you to it if you need to go away. Yeah.
No, I agree that, you know, there is a methodological problem. And I think the biggest issue that is kind of unaccounted for is the speed of the taper. So we know that, you know, staying on antidepressants versus relatively abruptly coming off them kind of, you know,
it's abrupt. It's very abrupt. Yeah.
For the most part, you know, it's gonna, you know, presents kind of, you know, shows things in favor of the antidepressant. So the question, I think, is how would antidepressant, you know, maintenance fare in comparison to a very gradual taper? And, you know, so that's the open question. And, you know, and we in this position, no one knows because that trial has not been done. Right. I think what you and I think many other, I think people would like to think is that, you know, hey, if they took these people off really gradually, you know, gradual hyperbolic tapering over, you know, months, years, we won't really see a meaningful difference from antidepressant maintenance. And, you know, maybe, but I don't know, maybe we will, you know, and so we can speculate in the absence of data about that. Now, I think the best, you know, I think the 2021 Lewis study that was published in New England Journal of Medicine, they tried to do a comparatively gentle taper, but even that was just 2 months. So they tapered people off over 2 months. Now I think I think for a lot of people, you know, 2 months taper is fine. You know, not everyone experiences, you know, very significant withdrawal issues with a 2 month taper. You know. But some people do, you know, some people are going to require. So there's this heterogeneity in, you know, like, you know, medication discontinuation experiences as well. I've seen people who just abruptly stop the medicine and, you know, they're just fine and they continue on. And I've seen people who have done, you know, taper over a couple of weeks and are fine. But then I've also seen people who have had to do extremely slow, you know, tapers too. So saying that, you know, just because a taper was, you know, relatively fast, it invalidates the entire results, I think doesn't take into account the heterogeneity of the, you know, discontinuation experiences too. But I agree, you know, like I said, we don't have good data to resolve this disagreement. So one, you know, at one end, someone who says that, you know, most of these cases, most of this discrepancy between rapid taper and antidepressant maintenance is mostly relapse prevention, and the other person who says that this is mostly withdrawal, you know, that disagreement won't be resolved unless someone does a blinded RCT. And then once we do a blinded, it'll be interesting. Now, I think recently, a few months ago, you know, there was a blinded RCT of benzodiazepine discontinuation, and in which people were kind of taken off the benzodiazepine, but they didn't know what dose they were taking. Now, interestingly, and perhaps somewhat counterintuitively, the ones who had the faster taper did better in that one compared to the ones who had a more prolonged taper. You know, what would a blinded, you know, antidepressant tapering trial would show? I think it's a really interesting question, and I really wish someone would do a trial, you know, so we get that kind of data.
If only there was a government organization who was tasked with investigating, you know, doing these types of very important research out there, you know.
You know, and I think it's important. Like I said, I mean, I wish NIMH would come up and make it a priority. And again, I think I want to emphasize that I think the fact that, you know, antidepressant withdrawal and PSSD got, you know, coded as anti-psychiatry really hurt things too. You know, it's because I think it basically pushed a lot of, you know, mainstream researchers who wanted to, you know, study things that are, you know, respectable. It just kind of, I think, disincentivized them because they didn't want to touch something that was, you know, so perceived as being so inflammatory.
Yeah. You'd hope they'd have the backbone to do so, though, you know, that they would have the, you know, the guts to say this has some real legitimacy. Yes, you know, it may be affiliated with some people who have positions that are much stronger than mine. You know, maybe there's some people in there who are throwing the baby out with the bathwater. but I'm a scientist and I'm going to, seek the truth rather than what's going to look nice, for the journal editors or for my peers. I mean, we have a duty to not back down from things that aren't comfortable. I mean, isn't that an awful thing, though, if you think about it, that researchers are saying, oh, I'm not going to touch this with a 10-foot pole. I don't want people to think I'm a Scientologist. Like that's...
No, I agree. Yeah, it's a problem. I mean, which is why I think, so even though, I, for example, hold a variety of positions that, that the iatrogenic harm community or the prescribed harm community isn't like. So I think a lot of the people in prescribed harm community see me as a villain because, I think medications are effective and they help a lot of people and they have a legitimate clinical use. But I think it's really important to talk about iatrogenic harm, and it's really important to be transparent with the public and with the patients as much as we can. So I defend this kind of thing, hey, we have a lot of people who are reporting, persisting sexual problems. We need to look into this. We need, we have a lot of problem with, protracted withdrawal issues. We need to study these things. So even though I don't get any kind of, benefit from, speaking out about this. Cause, like I said, a lot of people in prescribed harm, don't see me as an ally.
You get a lot of mean comments on Twitter because of it, so.
Yes. Yeah. But I personally, but personally, it is important for me to say, hey, I do think these medications have a legitimate clinical role, but it doesn't mean that, the subset of people is not being, harmed tremendously. And, we have a duty and a responsibility to that subset, and we cannot just ignore them, for the sake of others who benefit.
How do you feel about, I mean, when you talk to people about antidepressants and they go, Dr. Aftab is this safe long term? Is it safe is this drug going to be safe and effective long term? Do you feel like there's enough evidence for you to answer that question?
I personally think so. I mean, I think that there's also, I think when we talk about evidence-based medicine, for example, we have a certain idea of, hey, we need placebo-controlled, randomized data in order to confidently say such and such things kind of work, and so there's a kind of an evidence-based researcher idea of what, compelling persuasive evidence looks like. But then if you go on the ground and if you talk about, what the clinicians and what the patients consider to be actionable evidence, their threshold is pretty low and they're much more pluralistic. They are willing to, consider clinical experience. They're willing to experience, they're willing to consider the experience of other people who have taken something. They're willing to, for example, consider observational data and other things. So I think people, I think clinicians and patients, respect all kinds of observational data. They respect all kinds of clinical experience, and they're open to that. So, if I'm, for example, prescribing, let's say, a medication for depression, anxiety that doesn't have RCT evidence, but let's say has some observational backing behind it, and I personally have seen it, helpful. If I openly discuss that with the patient, I say, hey, it's not actually approved, it's not been studied in RCTs. I think it could be helpful based on so and so reasons. People are surprisingly quite a lot of open to that. I don't think that the average person is really that concerned about whether whether the evidence is coming from RCTs or no. And this also applies not just to medications, but to other things too. If you look at, for example, dietary interventions, like keto diet or other stuff, they're not, the average person is not going to say, I'm going to wait until there's a really high quality RCT of keto diet for, bipolar depression or whatever before I try it out. They will say, I have all these people who have tried it. It's quite helpful. What do you think? And so I think, I think when it comes to long-term use of psychiatric medications, I think people are more open-minded, especially because most people who are coming to psychiatrists, they are really desperate for relief. I've had people who experienced suicidality from antidepressants. We started antidepressant, they became suicidal, they stopped. I've had people who have had akathisia from antidepressants. I've had people who have had sexual side effects with psychotropics, and they're so desperate for relief that they still want to try more medicines. So I think people underestimate what's happening on the ground and what kind of needs people have.
It's really interesting because I think what gets lost in this discussion is the depression looks very differently. You can have some people who have tried every single lifestyle intervention and diet, and their social life is good, and they're suffering immensely, and they're ready to take medications. And from my perspective, there's nothing wrong with that. But then we also have people who are moving away from home, going to college. They're feeling a little sad, and they walk into the psychiatrist on campus who gives them an antidepressant when they really didn't need one or shouldn't have been given one. And so there's this, there's a dimension to it, in the severity of the depression, and at what point you just go, to hell with it. I don't really care about, the uncertainties of the evidence. I need something. I'm suffering. And there's a point for every single person where they will cross that line. And they'll say, yeah, I want to do it. And that's okay. And we shouldn't say that's an issue. I guess the problem that I have is, and this is just being very honest with you and sort of open-hearted about it now. I treat people with drug harms. I mean, that's what I do, so it's kind of different now, but I have done a lot of conventional psychiatry. When people come and they, if I were to counsel someone on antidepressants, I would say, there's no good evidence that these will reliably work long-term over a year, because that's about as long as the studies go. In fact, what I generally see is that people develop tolerance to them. They eventually need higher doses over time. Not everyone, but I can't, even in the 10 years I've been doing this, I can't think of that many patients. I put them on 50 of Zoloft and they were fine 2 years later. 6 months, 18 months later, we're doing a dose increase. That may lead to you being maxed out on a drug or another one added. Could potentially lead to you, having a side effect and being misdiagnosed with something else. Giovanni Fava, Rif El-Melek, there's other people out there who talk about neurotoxicity from long-term medication, antidepressant use, tardive dysphoria. This seems to be the rule with other psychiatric medications. Long-term antipsychotics at quite a high rate will cause tardive dyskinesia, neurological damage. Benzodiazepine-induced neurological dysfunction, that seems to be a norm as well. Lithium causes silent syndrome, cognitive impairment that's irreversible. Not in everyone. I mean, these are a fraction of the people taking them, and it's likely this is a small fraction of the people on antidepressants. But there's still a small group of people where the drugs could make them worse. And yes, there are people out there who have been on these medications for their entire lives, decades. They're doing well, and it's therapeutic. But then it seems like a dice roll to me. I don't, it's not good, because NIMH isn't doing this research. They're not saying, here's when the tolerance kicks in. Here's the frequency of this problem and that problem, because we're really studying long-term psychiatric medication use is a dice roll. And the more that I've learned about this, and I am biased because I work with people who are drug harmed, my comfort with prescribing them has gone from being, I'm quite okay with it a lot of the time, to these are only reserved for the people who have done absolutely everything else they possibly could do, and they're suffering immensely. And when I think about that, if I look at the people out there, I'm like, I feel like they're almost overused by a factor of 20, because I do think we have a massive overprescribing problem. And a lot of it, I think, is due to the fact, I know you mentioned the commercial forces, using insurance, very transactional visits, but it's also this understanding that they're safe and effective, for long-term use. It's so ubiquitous, There's all these people out there talking about it. And I'm really worried about that, because I wouldn't be able to look at someone that I loved and just be like, they're safe and effective. I would say for some people they can be, but there's a lot of uncertainty. There's a lot of uncertainty about it. I'm trying to be very real with you about kind of where I've landed.
And I hear you. I think the idea, I think the average person has a very I think, benign understanding of the long-term safety profile of these medications, which I think contributes to them, being more willing to take these medications than, than they perhaps they should be. And I think this is partly because the profession has not done a good job being transparent about these risks, with patients and the public. What the strategy that I think, makes more sense. And this is something that, guidelines, for example, like the NICE guidelines and, the Royal College of Australia and New Zealand guidelines, they've also moved towards that, is that move away from medication as a default treatment for mild to moderate depression. That for mild to moderate depression, start with psychosocial intervention, start with counseling, start with lifestyle changes, start with other kind of, group therapy, exercise, that kind of thing. And if kind of, like if the depression, anxiety issues are not resolving with those things, then you move on to medications as kind of, further down the road. And even for severe depression, don't rely on medications by itself, but rather use them in combination with other things. So I think, that has happened internationally. I think there has been silence on the American side. American Psychiatric Association hasn't even released a depression guideline in, I don't know, 20 years, right? So they're, they're behind the times in this regard. The second thing I think is that, anyone who is started on a psychiatric medication, including antidepressants, things, there needs to be a kind of like a discussion of what is the anticipated duration of treatment. And I think for most people, they should have an option that once they have recovered from an acute crisis and they're kind of, they're on their way to feeling better, there should be a discussion of, is the medication still needed at this point? Could you stay well, off the medicine? And I think if we did especially I think in primary care settings, but also in outpatient general psychiatry, if we took a lot more people off their antidepressants after an acute episode of kind of major depression, instead of just leaving them on, we would be exposing them to less, I think, kind of, long-term side effect. And so how to do that well is a good question too. Giovanni Fava, for example, has been interested in this question, and he has shown that if you do an acute kind of trial of acute treatment with antidepressant for a depressive episode, and you do it for 3 to 6 months, and then you taper them off while you give them cognitive behavioral therapy, people tolerate that really well, and a lot of people are able to come off their antidepressant and stay well, right? So that's a very innovative design, using antidepressant for a short amount of time for acute treatment, and then switching to psychotherapy for maintenance. We need that kind of thinking. But what happens is that people get started on an antidepressant, and they just there's no even discussion of how long should you be on it? What are the considerations involved? What do you prefer? And then this is compounded by a disregard for for side effects. So, for example, many people experience sexual side effects while on an antidepressant. Like 40-50% of people, some degree of it. And if a person reports to their psychiatric provider saying I'm on Zoloft and having this sexual side effects, and oftentimes the provider would just shrug and they would say, well, what is more important to you, not being depressed? Or right? I mean, like I've heard stories of providers reacting in that kind of manner, versus I tell when I kind of if I have someone on this long-term medication, I talk to them, hey, sexual side effects really common, withdrawal issues common, and I don't expect you to live with sexual side effects. I don't want you to live, I don't want a situation where a medication that you're on long-term is causing you sexual side effects. So if that is happening, we need to do something to try to we need to do something to address that. I think so. If we do a better job communicating that, and we give patients that control, if we say, hey, it's your decision if the costs of long-term treatment are kind of becoming more negative for you, and maybe it's better for your quality of life if you go off it. If we have these discussions on a periodic basis, the situation would look very different. Versus the current state is you just leave them on, and you have very minimal discussions about about these issues, and that forces patients to, when patients do want to get off, they just have to do it on their own, and oftentimes, without gradual taper, without a proper taper, which ends up in, further harm, because, they stop their medication very quickly, and then, then they decompensate after 3 months or whatever, and then the psychiatrist says, see, I told you that, if you went off, it's not gonna end badly. So it becomes a vicious cycle.
Yeah. I want to segue and just talk about one last thing before we conclude, because we've been talking for a while, and that is to go over to the NIMH, because and to set context, and maybe you can help, because my perspective on the NIMH is that they're really interested in brain-based research. They use something called the RDoC framework, where they look at neurocircuitry, they look at genetics, lots of different levels of study of the brain. But what they're not doing, and at least I haven't seen it, so you can correct me if I'm wrong, is they're not doing research that would help a lot of people. Like, for instance, how about a active controlled study with antidepressants versus psychotherapy, or psychotherapy plus lifestyle interventions like exercise or dietary interventions? Wouldn't that be interesting to see over 2 years, 3 years, 4 years, when we have potentially up to 15% of our population taking these medications, when there's open questions about how effective they are over the long term? That would be some interesting research to do. That might be the type of research that you could use to go to insurance companies and say, we need more time than 15 minutes with our doctors. And on top of that, we need professionals, embedded within PCP offices or somewhere accessible, where they can talk to patients, and they can do groups, and they can do things. They can help them with nutrition or lifestyle interventions, or there's actually people embedded doing, targeted psychotherapies for specific problems. Because we've got this great study from the NIMH that shows, X, Y, and Z. I don't know what it's going to show. I have a bias. My assumption is that it would lead to, it would be better for a lot of people, and it might be cheaper. There might be less hospitalizations. But it feels to me like the psychiatric leadership they're asleep at the wheel. They're doing esoteric brain-based research when there's massive problems right now. There's huge questions about the utility of long-term use versus alternatives, potentially less risky. There's big questions about iatrogenic harms. I know the PSSD people, they wish someone would study PSSD so they could have a cure. They're not really that interested in that. I'm not saying they need to be interested in iatrogenesis, but for really big issues like how does our standard of practice right now stack up next to alternatives? What are we doing?
Yeah, and I think so. My understanding is that there's a general sense at NIMH that the existing treatments are kind of pretty suboptimal, which is true. But they're like, we have these options. They work, but not that great. So we need to play the long game, where we try to study the mechanisms, what's going on in mental illness. And if we study the mechanisms, then hopefully in 15, 20 years, someone can use that to generate, actionable results. Now, so I think what this results in is a neglect of the actual real world clinical questions. So, for example,
Awais, do you believe that that's going to be true? That in 20 years' time, following RDoC, we're going to find the cure for depression in the brain?
Well, I don't know. Who knows? It's probably going to be. It might be longer, but I think I do think it's important to play the long game. We need the long game, because the government is the best place to fund it, but it doesn't mean that we neglect the other questions. So, for example, we have a wide variety of clinical treatment options, right? We have, we have dozens of medicines, but we also have, we have various psychotherapies, we have neurostimulation, and so a reasonable question for anyone interested in clinical treatment is, what is the optimal way of mixing and matching and, using, transitioning one to the other? What is the optimal way of using these treatments in coordination, right? if we had if that was a funding priority and we had good effectiveness data showing that, hey, if you do this first and then do this, you get better outcomes, it would be invaluable, rather than just individual placebo-controlled trials and then leaving it up to clinicians to figure out which ones to use first. And we saw that in other areas. For example, in cancer research, a lot of incremental progress was made just by figuring out the optimal combinations of chemotherapies. Hey, you have these different agents. What if you combine these two or these three chemotherapeutic agents? What kind of, survival benefit you get? In cardiology, we have these different agents. What kind of, survival benefits or morbidity benefit we get if we combine statins with this or that and that, right? So they invested heavily in these clinical questions to provide guidance. And, we have none of that in psychiatry. And for example, I'm particularly interested in the emerging neurostimulation, data. For example, I think there are people for whom probably the best first line treatment is TMS. I would say, they probably don't even need, it might be best for them to start off with TMS and, and if they do very well, they have avoided exposure to, pharmacology, etc. But I don't know which subset that is or how to even kind of go about thinking of it, right? Or how to combine kind of psychotherapy and neurostimulation in an appropriate kind of way, or, how to combine, for example, lifestyle, changes with, other interventions and optimum. These are questions that really interest me, but we don't know. And this neglect of clinical questions, results in a neglect of these hypergenic questions as well. What is the optimal tapering strategy of coming off, psychotropics, antidepressants, and, antipsychotics? We don't have that. The most recent CADMET guidelines on depression treatment, they tried to address the question of tapering strategy, but they essentially ended up saying, we don't have data to make a recommendation regarding what is the optimal, tapering strategy, because no one had that in RCT, looking at that. So, it's just, I feel very frustrated too that these ordinary real world clinical questions are being neglected in the research world and in the academic funding world.
Why do you think there's, and this is just from my vantage point, it seems like psychiatrists are okay with the way things are. Or maybe they grumble sort of privately to themselves and go, oh, it's kind of bullshit. I wish we had more research. But we're not organized in any way. We're not speaking out. We're not saying, hey, NIMH, you need to be doing this. FDA, you need to be doing this. Guys, we need to be guiding our family medicine colleagues more. There's an overprescription like crazy. We need to be doing something. What's happening in the profession that it just seems so complacent when there's so many problems, where there's solutions? There's research that could be done. There's training that could be done. There's so many ways we could lobby our government and professional institutions to change things. Why do you feel like, maybe this is just me, why are we so complacent as a profession and just letting things be the way that they are?
Yeah, I think it's partly because I think a lot of people exist in these epistemic bubbles where they're not even being exposed to these things. So for example, like the antidepressant withdrawal stuff, has been huge online for many years. I think anyone who has been somewhat active on Twitter or blogosphere, even in, let's say, 2018, 2019, they would be aware of, hey, this is a big deal. People are talking about this. But, 5 years ago, I was talking to a kind of a group of psychiatrists, kind of colleagues, and they're not very active online. I think they don't even have an online presence. And I'm telling hey, this antidepressant withdrawal stuff, it's it's affecting a lot of people. It's a big deal. And I'm getting kind of blank stares. It's not even, they haven't even heard of, like people having really severe difficulties with that. Yeah, right. So I think they had just been kind of living in their bubble where, people stay on medicines, or if they go off, then they restart the medicine, and so they just, they're not it was not a part of their everyday kind of world where they were coming across that. And so I think, how do we break down these silos that, people are getting exposed to these issues is, I think, part of is part of the issue. Um, and I think sort of like, I think so discussions like this, I think help, but, I think having other ways of communication so that people can't just go on ignoring these questions and rather actually have to confront that, people are having these difficulties. I think if there was kind of more back and forth communication with the public, it would help. Now, there's a lot of defensiveness in the profession too. I remember, I think it was 2018 or 2019 when New York Times did a big story on antidepressant withdrawal, saying, hey, a lot of people are having difficulties, and there were 40 psychiatrists from kind of various academic institutes in the kind of Upper East Coast area. They wrote a reply to that New York Times article saying that, hey, we speak as experts in kind of mood disorders, and we say that withdrawal is low on the list of priorities for clinicians and patients. And they didn't mean that as an admission of guilt. They meant that, hey, this is not a big deal. Why are you taking this seriously when we are not? And I read that letter and I was like, how can you say that? How can you come on record and say that, hey, this is no priority? Okay, maybe it is no priority for you, but for the people who are suffering from it, it's obviously not low priority for them. For even if it's a small percentage of people, for them, it's a life derailing stuff. And, we need to take that seriously. So I think that the defensiveness of the profession that, if we get publicly criticized, we should just kind of automatically push back has been very detrimental.
Yeah. Yeah. It's been hurtful for the people suffering as well. I want to wrap now by asking you maybe the hardest questions of the day, and sorry for saving them for last, but I do think they're interesting to ponder. And so my question to you is, you're the president of the APA. You've been elected to lead the professional body of psychiatrists in the US. Gut feeling right now. What's on your agenda?
I think, being APA president is probably more ceremonial than it's my actual power. Let me give you an example. Just a few years ago, one of the APA presidents made social determinants of health the agenda, right? So that year, they wrote multiple editorials about how social determinants of health are important. The whole theme of the annual APA meeting was about social determinants, huge panel discussions about social determinants, right? So the biggest platform that, APA could provide, was provided to the idea of social determinants. But what meaningful practical change did that result in? Nothing, right? So I think there's this, I think there are things we could, say and highlight, but then if we don't have ways of, affecting clinical practice and doing that, it doesn't really result in a lot of outcome. Now personally, for example, like, a thing that I have been working on for many years, that's on the psychiatric education side, is something called conceptual competence. That I think a big issue is that people who are, practicing clinically, they don't have a good conceptual grip on what is it mean to say that a behavior is disordered? What kind of judgments are involved in psychiatric classification, et cetera, et cetera. And I think just as we expect, clinicians to be clinically competent, we expect them to be culturally competent, structurally competent. I think we should also expect them to be conceptually competent too. So that's been a big thing for me, and it has been a focus of my academic and educational work, and I wish there would be more of that, but I would fully acknowledge that simply having conceptual competence is not going to result in meaningful practical change, because the path to practical change is more complicated, and it requires socio-political action in a way that just talking about something doesn't result in automatically.
Yeah. Well, on that note, I'm going to ask Is there anything that we haven't talked about which you did want to mention, or that you think might be interesting for the audience to hear before we wrap?
Yeah, I think one thing that I've noticed, I think around in these discussions, and especially kind of discussions in online communities, I think different people belonging, I think, in patient groups, but also, different clinicians working with different patient populations tend to develop ideas that might be a good fit for that population they work with, but might not apply very well in other settings. So, for example, you work, these days a lot with people who have had prescribed harm issues and who have had withdrawal issues and need kind of gradually dipping stuff. Right. Other, for example, like, people who are in, let's say, psychodynamic psychotherapy private practice, they're working with a very different group of client. Some people who are into lifestyle psychiatry, they work with people who are really motivated to try dietary interventions. And so I think interventions and ideas that have appeal in certain contexts don't necessarily translate very well to, other, in general context. So, for example, in a public kind of, psychiatry outpatient kind of setting, you're not going to get a lot of people who are super motivated to try dietary intervention as a primary treatment modality. Or you might not get, people who are super motivated to, first start with exercise as a treatment modality. So even if, for example, I might tell the patients, hey, like there's this promising data around dietary interventions and exercise, I think it could be really useful. Unless you're working with a group of patients who are really motivated to do that, you're not going to get the same kind of result. So I think when we talk about what works for people and what benefits and what harms, we have to keep that heterogeneity in mind, that different patients have different needs, they have different expectations, they have different capabilities, and there is no one size fits all. And things that can be really harmful for some people can be really beneficial for others. And so I think the less, if we can scale back our generalizations and acknowledge the heterogeneity of these things at all levels, we would all be better off, and we would all start from a little bit more, position of humility.
Mm-hmm. Well, on that note, I want to thank you so much for taking time out of your day to come and speak with me and my audience.
Yeah, thanks for having me.
And so that's it for today. If you found this video helpful, please consider liking and subscribing to the channel. It helps more people out there on YouTube find this kind of information. Thanks.